Hello, everyone, and welcome to the Digestive Disorders, which is covered in Chapter 13 of your primary textbook. You are listening to Claire Richter, who is the instructor for the classifications course in Year 1 and Year 2 at the Center for Distance Education. So, as I've done in previous chapters, I'm just going to give you the highlights and what is really important and information that I think probably needs to be explained by voice. And this is mainly, as I said, probably in previous recordings. It's taken just from things I've noticed as I've been marking assignments. So they're common errors that carry on even past this chapter. So obviously just reading it wasn't enough. So let's see if this will help people who aren't just visual learners. All right, so as I said, we're going to cover digestive disorders today. And let's see if my computer will play along with me. There we go. So the first piece is the GI hemorrhage or gastrointestinal hemorrhage. As your textbook says, there are some code categories that have combination codes for bleeding/hemorrhage, and some do not. So if there is no combination code, then you would need to assign an additional code for the bleeding or the hemorrhage. Patients may have a history of GI bleeding and they're brought in for investigation. So even if bleeding is not found on the day of investigation, because the patient has a history of it, and that's why the patient's being brought in for an investigation, it should still be coded. There are 4 types of GI bleeding. There's hematemesis, which is vomiting and blood. It could be coffee ground or bright red in appearance. If it's coffee ground, it usually means that it's a lower intestinal bleed, and if it's bright red, it's an upper intestinal bleed. So those are just things to keep an eye out for, and it's coded to K92.0. There's melena, which is black tar-like stools, and they're usually thick and sticky, and that is counted to or coded to K92.1. Occult bleeding, this can only be found on a lab sample. So if the doctor is asked for a fecal sample to be done and they find occult blood, then we would code it to the R19.50 fecal occult blood test, or in abbreviation, a FIT test, F-I-T. And there's something called hematochezia. And essentially it just means that there's hemorrhage in the intestine. So if the source of the blood, if they've done an investigation and they find that the source of the blood is the rectum, then we could code it to K62.5. And if we go to our ICD-10, and I use my go-to arrow and I just type in K62.5, it takes us to a hemorrhage of the anus and rectum. So if that's where they determine that the source of the blood is coming from, then that's where we code it to. If there's no indication of where the source of the blood is coming from, and they just call it hematochezia, then we would code it to just plain K92.2. And that is just a GI hemorrhage unspecified. Now you notice in here, nowhere is there the word hematochezia, and if we tried to search for it, we would not find it. Oops, how do I spell it right? Hematochezia. And you notice I get 0 hits. And I believe that's the same on, so it's the same on the big binoculars as well. So that's just a code that you need to remember, is if the doctor calls it hematochezia, then what he means is just GI hemorrhage unspecified, K92.2. When we talk about gastroenteritis and diarrhea, quite often the two go hand in hand. If people tell you they have stomach flu, what they really have is gastroenteritis. It's usually associated with diarrhea and vomiting. So in the coding database, gastroenteritis, colitis, which is inflammation of the colon, enteritis, which is inflammation of the small intestine, and diarrhea all mean the same. So when you're searching in ICD, all of these 4 terms mean the same thing. So one we would want to search for is enteritis, and the only reason for that is that as a lead term, it gives you more options for subterms. And we can go and have a look at that as well. So if I were to search for gastroenteritis, gastro, and it fills it in for me. And I hit the OK button. So it will also tell me to see also enteritis, but it gives me a few options. So there's allergic, there's chronic, there's due to a few things, there's eosinophilic, non-infectious, septic, salmonella. So it gives a few options, but not too many. But if I went, I'm just going to use a hyperlink instead of searching again. But if I look for enteritis, you'll notice as I scroll down, there's a lot more that I could choose. And it also gives you a lot of choices for different types of infectious enteritis. So there's your C. difficile, Clostridium difficile. There's your E. coli, Escherichia coli. Those two are very common types of enteritis. C. difficile, you'll quite often notice, pardon me, in more elderly patients. It seems to attack when your immune system is lower. But they also get it a lot in hospitals. So if there's anything going around the hospital, it will likely be a C. difficile infection, and those patients will be quarantined because it is very contagious. E. coli, you hear that a lot, that people get E. coli infections. There's staphylococcus, there's all sorts. And as we keep on scrolling down, you'll notice it's all, the list is huge. So if you have some sort of type of enteritis mentioned, you can enter that as a secondary term and narrow it down. Or you could just do what I'm doing now and go to enteritis and then just scroll. So those are your options. But try to search for enteritis as your lead term because it's just so much more robust for options for coding. Again, there's going to be some combination codes can be found for some types of gastroenteritis, so pay attention to the subterms. So, for example, the E. coli and C. diff that I told you as I was pointing out in the codes. Diarrhea, when it's unspecified, is classified to infectious, which is A09.9. If they've described it as chronic diarrhea, then that takes you to a K52.9 code. So infectious diarrhea, it will default to if we don't know it's chronic. Dehydration, as you can imagine, when you're vomiting and have diarrhea, it is normal with gastroenteritis. So we don't code dehydration along with gastroenteritis unless the patient is having to come into hospital and they've given IV in order to rehydrate that patient. So if they do IV rehydration, then we must code dehydration as a type 1 along with the gastroenteritis. We do not code the intervention code for IV rehydration because we only code dehydration when the patient is given IV rehydration. So that's just one of those coding conventions we need to remember. Inflammatory bowel disease, or IBD, it can encompass a whole bunch of different types of inflammatory bowel disease. So if it's the only thing mentioned and we can't find anything more specific, then we code it to the K52.9. And if you remember on a slide back one or two, chronic diarrhea went to K52.9. So what we're saying is that chronic diarrhea and inflammatory bowel disease are the same thing, unless you can find some sort of documentation in the chart that tells you a specific type of inflammatory bowel disease, such as ulcerative colitis or Crohn's. And those have their own specific codes. Patients who have progressive weight loss for any kind of reason, in order to avoid malnutrition, they're usually put on some sort of nutritional support. That can be done in the community through those Boost cans, or if it's severe enough, then they have to come into hospital. So there's something called TPN, which is total parenteral nutrition, and it is liquid calories and protein that's directly inserted into the circulatory system. So the patient comes in and they get a central line, otherwise known as a PICC line, inserted, and then they're hooked up to the TPN. So it can be given via an IV pump or a central catheter, and that's that PICC line that I just mentioned. So an additional code for that catheter is mandatory to code. So if we went to my CCI database, so I'm in CCI, and if I use a big binocular and I just type in TPN, okay, what it stops me at first is that implantation of internal device, vena cava, And here we've got the CBC, we've got PIC. There's a whole bunch of different ones. So it actually stops you at that insertion of the catheter code first. So, and here it says that for administration of drugs, fluids, TPN, or hemodialysis. So we would stop here, code the appropriate code from our table, and then we would go forward because this just covers the insertion of the catheter. We still need to code something for the TPN itself. So here it says code also any administration of TPN. So we can either do the hyperlink to the 1LZ35, or I can just simply go forward one. Oh, no, too far. If I go forward one, it's not going to do what I want it to do, but it takes me to the parenteral nutrition 1LZ35. So it's the same code if I clicked on the hyperlink. And here we get to pharmacotherapy local circulatory system. So remember, TPN is circulatory. And then we want of parenteral nutrition, and then you would choose how it was administered. So percutaneous infusion. So if they've done that catheter insertion, then this is the correct one. So remember that a catheter-directed intravenous, is infusion. It's not injection, it's infusion. If they just insert a needle, then it's an injection. So here we choose the 1LZ35HHC6 along with that 1IS53 code that we were just at for the implantation of the device. Okay. Now you've probably heard of other ways of feeding patients. So that one is specific to the circulatory system, but you probably heard of like a feeding tube or a gastric tube or an NG tube. These are what we call enteral nutrition, and it's liquid calories and protein that are given directly into the digestive system. And it's usually done via the nose. They insert a catheter up or down through your nose, through your throat, into your stomach. And that's what they call an NG tube for nasogastric tube. Now, this can be done on the nursing unit, so it is only mandatory to code in ambulatory care, as opposed to TPN, which needs special care, and it's mandatory to code regardless of when it's given. The other note that I have for enteral nutrition is that sometimes it can be given via gastrostomy, like a PEG tube, or a jejunostomy tube, and these are mandatory to code for inpatient and ambulatory care. And that, again, is because they would need a special room. So they would probably go down to radiology and have a specialist insert them for them. Then we get to appendicitis. Now, appendicitis can happen with or without peritonitis. Pardon me. Peritonitis usually means that there is an inflammation of the peritoneum, which is the lining of the abdominal cavity. So if the appendix has ruptured, you are more likely to get peritonitis. It can be described as generalized or localized. So if it's not specified as generalized, then we code it to localized. And that just means that the infection is located in the general area of the appendix. If it's generalized peritonitis, that means that most of the abdominal cavity, the lining of it, has been infected by this peritonitis. So the appendix can rupture during removal. This is not a complication, but it is coded to localized peritonitis. So even if there's no evidence of an inflammation of the peritoneum, if that appendix ruptures, what it means is that the stuff that's inside the appendix is now outside the appendix in the abdominal cavity, and that will likely cause some sort of infection. So if the appendix ruptures, we have to code it to localized peritonitis. So if we go to the appendix codes, so I'm back in my ICD, and I know that appendicitis is in K35. So I've got acute appendicitis. Here's my acute appendicitis with generalized peritonitis. And here's my acute appendicitis with localized peritonitis. And then there's acute appendicitis other and unspecified. So if there's no mention of rupture or peritonitis, then we code it to this K35.8. Okay. Patients can present with clinical signs of appendicitis. So that means that they have pain in their lower right abdomen, or what they call rebound. So if the physician's pressing on the abdomen, it makes a sound when they tap on it. And those are clinical signs of appendicitis. But when they actually go and take it out, the pathology says there's absolutely nothing wrong with the appendix. It's normal. So what we do is we code the symptoms the patient arrived with. It could be abdominal pain, upper quadrant pain, any other signs that they arrived with. Or if once they get inside, the physicians realize, oh, it wasn't the appendix at all. It was, let's say, for example, an ovarian cyst in a female patient. So the cyst may have ruptured, which caused the pain that brought the patient in. And just on clinical observation of the patient, they looked like they had appendicitis. So when they took them in, turns out it wasn't the appendix. It was actually a ruptured ovarian cyst. But they're going to take the appendix out anyway, because that's why they were there, and it could get inflamed. And really, science still hasn't figured out what the appendix is actually for. So for now, they still remove them once they're already in there for that purpose. So that's one you could, and it looks weird when you code it, because you end up coding an N83 code for the ovarian cyst, and then the appendectomy code. So it just looks weird, but you're actually coding it correctly. So if they've made some sort of diagnosis, we would code that. If they haven't, you just code the symptoms. And you do not code appendicitis when the path report says the appendix is normal. And as I noted there, you'll still code the appendectomy as the intervention. Sometimes the appendix can be removed during a different intervention. So if they've gone in there for something to do with the colon, or they've gone in there to do something with the female reproductive system, they can actually just remove the appendix while they're in there. And this is what they call an incidental appendectomy. So if I were to go to my CCI again, and I type in appendectomy, okay, so we've got one NV89, which is excision total appendix. This is where I'm going to find where it is, because all I have here are the options of how they did it, so the approaches, whether it was endoscopic or open. So if I click on my status attribute, here's that incidental. So if that appendix was removed incidental to another intervention, I would put B in that status attribute. The C is if they start that surgery laparoscopically, but maybe the patient's had abdominal surgery before and there's adhesions and they really can't get to the appendix, or it's stuck to the abdominal wall, then they can convert from an endoscopic to an open approach. We would choose C. If they go in and they abandon the surgery completely, we would code the A. If it's not any of those things, we would just choose the 0, not applicable. Okay. Hernias. Hernias are classified by their location. So the inguinal hernia, which is in your groin, it's the most common type of hernia. It occurs more in males than females, and it can be described as indirect or direct, but that doesn't affect the code. Many years ago, the coding used to be broken down into direct or indirect inguinal hernias, but that is no longer the case. That's terminology that is not used currently, but you will find older physicians still use that terminology, and it is still available in the ICD database. So if they call it a direct hernia, you can still find it. It just doesn't affect the coding anymore. There is a femoral hernia, which is where a loop of intestine has slid down into the femoral canal, and that is more common in females. There's an umbilical hernia, which is usually found in children, and that's where the abdominal contents come out through the belly button, through the umbilicus. There's a ventral hernia, which is where abdominal contents come out through an abdominal scar. So if you've had any kind of abdominal surgery, you are at risk for a ventral hernia. It can also be called an incisional hernia. It is only a post-intervention condition when documentation specifically relates it to a previous surgery. So they could have had abdominal surgery in the past and come back with a ventral hernia, but unless that physician actually relates that hernia to that surgery, we cannot code it as a post-intervention condition. We would just end up coding it as a hernia. If the physician does relate it to that surgery, then we end up coding it as a post-op or a post-intervention condition. There is a hiatus hernia, which can also be called the diaphragmatic, and that is between the esophagus and the stomach. So the complications of hernias can be obstruction, can be incarcerated, which means it's trapped, strangulated, which means it's trapped and strangled, and irreducible. It means that they are not able to push it back to where it should go. So all of those are coded to with obstruction. And another combination code that exists for hernias is with gangrene. And you'll quite often find that with a strangulated or irreducible hernia, because the bowel is then being cut off from blood supply, and then they get gangrene. Adenomas and polyps. These are common in the colon. They can often lead to malignancy, so they are removed when they're found. They are found during colonoscopy, and they are removed. If they find it and they remove it in its entirety, the physician will call it a biopsy. But for coding, we know that something that's removed entirely is actually an excision. So you would end up coding a partial excision of the colon. Quite often they call it an adenomatous polyp, and the surgery they'll call as a biopsy of the large intestine. But we can't code it to a biopsy, and this is where it's important that you have to read the details in the OR report. So if they take out that entire polyp, and they'll tell you that they do, if they take out the entire polyp, then we code it as a polypectomy, which is partial excision of large intestine. And then we have to add a code to tell them, or to tell us, what tool was used. So was it done via colonoscopy or sigmoidoscopy? If they only remove a piece of the polyp, if for some reason they weren't able to get all of it, then we would code it to a biopsy because they haven't removed the entire thing. But normally polyps are quite movable. They just go in and they snip off it at the base and take out the entire thing. And then we use the pathology report, which would guide us to the appropriate type of neoplasm, whether it's a polyp or whether they actually found cancer in that polyp. Diverticulosis and diverticulitis. So you'll find that they use those terms interchangeably in charts, but their actual meaning is different. So diverticulosis means the presence of disease without inflammation, and diverticulitis means the presence of disease with inflammation. To make things easier, we code them to the same category in ICD. So regardless of which term they've used in the chart and whether they've used it interchangeably, the codes all go to the same area. So just to make it easier and you're not second guessing which physician is correct in their terminology. Ulcers. So peptic ulcer disease includes gastric, duodenal, and gastroduodenal ulcers. If a physician diagnoses peptic ulcer, you need to search the documentation for a more specific site, because peptic ulcer, as it said above, can include any of the GI system, and we need to narrow it down to where the ulcer is. So we should try to avoid peptic ulcer coding unless we cannot find any other documentation. If the patient is being treated for the ulcer or they're being some sort of diagnostic test done for it, there should be an OR report or some sort of surgical daycare report that should tell you at least what area they're looking at for this ulcer. So ulcers can bleed, and they will sometimes lead to acute or chronic blood loss anemia. The anemia should be an added code if it extended the stay or required a transfusion, and it would be type 1. Now this is an example. If you remember way back in the beginning, I talked about upper GI bleeding. So ulcers can bleed, but it doesn't necessarily mean that when that patient comes in for the investigation that the ulcer that they find is currently bleeding. But because the patient has a history of bleeding, we still would code that ulcer to a bleeding ulcer of whatever site it's in. Okay? And then again, if that bleeding then leads that patient to be anemic and they have to treat it, then we would code the chronic blood loss anemia. Adhesions. So I briefly touched on this before when I was talking about the appendix, but adhesions usually occur because of previous inflammation or previous surgeries. So if you think about it, if you're entering the abdominal cavity or the pelvic cavity and you're messing around in there, everything's getting moved around, and you've introduced or you've cut away things that were in there. The body is going to try to attach whatever is left to the abdominal wall. And it's not normally a concern unless they cause bowel obstruction. So it can be seen during an OR, but we don't normally code it unless the adhesions prevent the surgeon from accessing the area he was going to operate on, and he or she has to spend time releasing them. So you'll often see them mention adhesions in the surgery. If they just go through them and it's not a problem, then we wouldn't even bother coding them. But if the surgeon says there's extensive adhesions and they're talking about they're having to lyse or to cut, so we code lysis of adhesions. If they're having to spend a lot of time cutting through that before they can get to the organ they're actually looking for, or in the case of pelvic surgery, so you're quite often going to have a gynecologist working in a female patient. If the patient has extensive adhesions, they will likely have to call in a general surgeon to come and cut away all those adhesions to make sure that they're not cutting any organ they shouldn't be, before the gynecologist can continue on with their surgery. So they can be quite time consuming and quite resource intensive. So if they're talking about that, then you would code the abdominal adhesions and the lysis of those abdominal adhesions. This is the one that I see errors on quite often. So it's endoscopic per orifice interventions. And that includes anything from esophagoscopy, gastroscopy, duodenoscopy, colonoscopy, sigmoidoscopy. Now the key is, if all they're doing is viewing the patient, they're not doing any biopsies, they're not excising anything, they're just viewing the system, we code the farthest site viewed with that tool. So they can call it a gastroscopy because they use a gastroscope to go and look. But if that gastroscope, and during that gastroscopy, they view the small intestine, then we would code a duodenoscopy. So even though they haven't called it that, if they view it, we code it. So then we would not code the esophagoscopy and the gastroscopy. We would only code the duodenoscopy. If they go in and they stop at the stomach, they don't view the small intestine at all, then you would just code the gastroscopy and you would not code the esophagoscopy because they've gone through the esophagus into the stomach to view that. And it's the same idea if they're going from the bottom end up. So if they're doing sigmoidoscopy or colonoscopy, if they use a sigmoidoscope and they only look at up to the sigmoid colon, then you code sigmoidoscopy. If they use doing a sigmoidoscopy, but they use a colonoscope, which allows them to see farther than the sigmoid colon, then we end up coding a colonoscopy. And it's always a good idea to have a look in the notes in the chart and find the booking form to find out what that patient is booked for. 9 times out of 10, that patient will be booked for a colonoscopy. And if that's the case, then we code the colonoscopy, because not only does the room prep for a colonoscopy use more resources than a sigmoidoscopy, but the patient prep is very different. So the patients had to take extra medication and spend extra time getting prepared for a colonoscopy versus a sigmoidoscopy. Now, if a biopsy is done, we code the biopsy, plus we also code the farthest site viewed. So if they do a biopsy of the stomach, but they still continue on to look into the small intestine, we code the biopsy of the stomach plus the duodenoscopy. So you'd have 2 codes. Okay. And the only caveat there is unless the biopsy is at the same site. So if they do a biopsy of the stomach and they only view the stomach, then you would just code the biopsy of the stomach. So there's my examples. So an EGD with biopsy of stomach, code the stomach biopsy and the duodenoscopy. EGD with biopsy of small intestine, you code the biopsy of the duodenum only. If they do more than one biopsy, so they biopsy the stomach and the duodenum, then you code both biopsies. So my only other note there is to watch the use of optical biopsy, and that's the NK70BN. This type of biopsy uses lasers, and it doesn't take tissue samples. So if you have a pathology report on your chart, then it is not an optical biopsy. So what the laser does is it shines onto the tissue, and it allows the surgeon to see through the top layer of the tissue to what's beneath it without having to take physical samples. They can just see it. This is probably more common now, but none of the charts you'll be working with in school are actually optical biopsies because we have older charts. So I'm just going to go to that code actually. So we'll say it's the small intestine, so 2NK70. So here's your endoscopic per orifice using a colonoscope. So that's when they've gone from the bottom up to see the small intestine. If they've used a gastroscope, then that's going from the mouth down. Watch the use of this antegrade endoscopic per orifice approach and double balloon enteroscope. So even though they may have looked into the small intestine, we still can't say it's an enteroscope because it's not a balloon enteroscope. So just watch using that one versus these ones up here. These top two are the most common ones. And here's this laser-assisted optical biopsy and colonoscope or gastroscope. So again, unless they've actually mentioned a laser and they have not taken any tissue whatsoever, then it's not these ones, it's the top two. Colonoscopy. So colonoscopy can be used to view both the large and the small intestine. So again, the colonoscope is really long because it has to go all the way from the rectum all the way up through the large intestine, which is 40 some odd feet long. And they can actually get into the small intestine. So if they view the small intestine with a colonoscope, then you would code, as we did on the previous one. Oh, no, sorry. If I went back to here, inspection of small intestine using the colonoscope. Okay, so your large intestine is the anus, the sphincter, the rectum, sigmoid colon, descending colon. This is your splenic flexure, your transverse colon, the hepatic flexure, and then your ascending colon. Okay, and this attaches to the cecum. So the cecum is the terminal end of the large intestine. If they view into the ileocecal valve or into the ileum, you are now in the small intestine. Okay, and there's that appendix that they still don't know what it does. So just a note there. So if they view into the ileum, you're now in the small intestine. Okay, so you need to know your intestinal anatomy. You need to know all these parts of the large intestine so that you know what they're viewing. Oh, and here's that note, or here's an actual slide on what I was talking about with colonoscopy versus sigmoidoscopy. So sigmoidoscopy should only view the sigmoid colon because a sigmoidoscope is a shorter instrument. So pay attention to what the OR report says, what instrument was used, and how far they viewed. Look at the surgical booking form to see what the patient was booked for. Okay, so I covered that a couple minutes ago. Laparotomy and laparoscopy. Only code that if it's the only intervention performed. So quite often, let's say laparotomy with partial excision of large intestine, or laparoscopy with excision of appendix. What that just means is laparotomy simply means incision into the abdomen, and laparoscopy is viewing inside with an endoscope. So unless all they do is a laparotomy or a laparoscopy, and they're just going in to have a look around, then we don't code it at all. More often than not, it's just the approach to however they did another surgery. So laparoscopic appendectomy, laparotomy with removal of partial excision of the intestine. The actual procedure was the partial excision of the intestine, or the appendectomy. The laparotomy and the laparoscopy were just approaches, so how they got inside the patient. Okay, so when we actually look at doing that in a code, go back to that, oops, wrong one, NV89, go back to the appendix. So here is your endoscopic and here's your open. So if they did a laparoscopic appendectomy, we would simply code 1NV89DA. And that DA part means laparoscopic, and the LA means open. So we would not also then go code laparoscopy, because this code covers both things. I mean, they will look around. So once they're inside the patient, they're going to have a look around at all the surrounding structures, but that doesn't necessarily mean that that was the intent of why they went into that patient. So that's why we don't have to code it separately. Okay, so that ends that one. And so just remember that these were just the highlights from that chapter. So be sure to read the rest of the chapter and feel free to ask me any questions that you might have. Thanks for listening.